Welcome everyone to today's webinar, How Cedars-Sinai Tap Change Management Principles to Better Inform Surgical Service Line Decisions. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. You will find a few different engagement tools on your dashboard. Please check out our resources section and also make sure you fill out our session survey. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Lastly, if at any time you have trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions in the Q&A box. We're here to help. It is now my pleasure to introduce our speakers for today. First, Dr. Harry Sachs is the Executive Vice Chair and Professor of Surgery at Cedars-Sinai Medical Center in Los Angeles, California. He is joined by their Director of Robotics, Dr. Daniel Shohead, and Executive Director, Alfonso Chicas. Today, they will share several strategic initiatives they've adopted to increase patients' access to minimally invasive surgery and help achieve the quadruple aim. Gentlemen, thank you for being here today. The floor is yours.
Well, thanks very much, Ayla. And on behalf of my colleagues, Danny and Alfonso, we too want to thank Becker's for giving us this opportunity to share our journey and also to Intuitive for their ongoing support in advancement of our minimally invasive surgical service line. I think anybody who is in a leadership position wants to do the right thing for their patients, wants to do the right thing for the people that are working with them. And you have to do that using data. And sometimes data can be subjective, sometimes it can be confusing, but I want to show you how sharing data and how using data has really helped us drive ourselves forward. For those of you that don't know about Cedars-Sinai, it's actually initially began back with Cedars of Lebanon Hospital and the Mount Sinai Hospital, and around the turn of the century, around 1900s, it was not uncommon that the Jewish populations of various cities began hospitals both for their patients as well as for their physicians. Over the years, the quality of both institutions continued to improve as well as demand for services. And in 1961, they merged to form Cedars-Sinai Medical Center, and then in the 70s, actually moved on to our current site, which is at the border of West Hollywood, Los Angeles, and Beverly Hills. We're one of the largest nonprofits west of the Mississippi. We have close to 900 beds, and like you, I'm sure in many cases we have all those filled and more. And we are really committed to resident education, both residents and fellows. One of the things that we're most proud of is because of our long history of innovation, especially innovation in minimally invasive surgery, we were one of the first 3 MIS fellowships in the country. And we've had a lot of leaders and a lot of very innovative things that have happened here at Cedars-Sinai. In fact, until I got here 10 years ago, I didn't realize that Dr. Swan and Dr. Gans, who created the pulmonary artery catheter, did that here at Cedars. We're fortunate that Dr. George Bursey, truly one of the pioneers in minimally invasive surgery, who has had quite a life, and in fact, this month is turning 100, and his office is 2 doors down from where we're speaking to you right now, was just an incredible force in looking at lighting, cameras, and minimally invasive equipment. In areas outside of the operating room, Eduardo Marban, who we recruited from Hopkins, has had a really interesting career, and working with our Regenerative Medicine Institute has been exploring the use of stem cells in improving end-stage heart failure. And many of you probably recognize Dr. Ed Phillips, one of our busiest and most prominent minimally invasive surgeons, has been president of multiple surgical societies, and did one of the first lap choles, and has also helped us both on growing our regular minimally invasive laparoscopic program, as well as being extremely supportive as we moved into robotics. Now, again, I've been here since about 2011. I was previously at Brown in Rhode Island, and at that time in 2006, we brought the first robotic platform into the state of Rhode Island that required a certificate of need and quite a bit of effort. So not surprisingly, because of the strength of regular laparoscopic surgery, in 2003 and through 2008, Cedars did have some robotics technology, some of the early platforms. As we grew in the last decade, we had an S, we had an SI. We then added some X's and XIs, and we were at about, in 2017, about 4 systems. We're doing a good number of surgeries, but the problem was that we had far more demand for the platforms than we actually had available time. And this became an issue both from an efficiency and a quality point of view, because we wanted our surgeons that were committed to minimally invasive surgery to be able to get to the platforms. At the same time, the economics of investing over $2 million in a platform that may only be used intermittently was quite difficult. In 2018, I attended a meeting at NYU where Intuitive rolled out the concept of the AMP program, which moves from a capital purchase to an operating purchase, essentially a lease on the platforms. And with that, we were able to grow the number of platforms with a relatively low risk. And more importantly, we were able to update and standardize. So we are now an all XI fleet. That gives us tremendous help in training of our personnel, as well as in our inventory, because we don't need to have separate S, SI, X, and XI equipment. We have recently now added, in addition, the SP as well as the ION. And again, the use of this different type of financing has been quite helpful. And I'll talk to you a little bit more about how we make the decisions on which systems we use for each. As you increase access, not surprisingly, volumes increase. And you can see that some of our greatest increases have been in general surgery and in gynecology. And what was really not surprising is, as you look, and I think that my arrow is showing you, we actually had a moderate GYN presence, but because of some of the issues I had discussed with you with access, 2 of our busier and more talented GYN robotic surgeons chose to move elsewhere. So it's only been lately where we've been able to expand access that we've been bringing a lot of people back in and recruiting new people from all over the world. Where are the potential areas? Remember that we want to be looking at converting from open surgery as much as possible to some form of minimally invasive surgery. And bariatrics made that move probably about 15 years ago with laparoscopy. But again, with bariatrics, in many cases, you also get into complex redos where you have sleeves that perhaps have failed, you have strictures, you have issues with the Roux-en-Y pouches. And in those cases, robotics really gives us tremendous advantages, especially on redo surgery and especially on things high up into the esophageal hiatus. Inguinal hernias, again, we still have a large number of open inguinal hernias being done. We have a pluralistic medical staff. Many of our surgeons may not be as comfortable with straight laparoscopic hernia repair. Ventral hernia, again, where do we get into trouble with ventral hernia? It's with enterotomies. And trying to do these hernias laparoscopically sometimes is quite difficult. And then GYN, and then moving into some of our more advanced procedures, such as hepatobiliary. Well, when we try to grow a robotic service line, and this is not unique to a robotic service line, but anytime that you're trying to grow a service line, you've got to think about what are the clinical implications, what are the financial, and what are the operational. We're full. We are really working on reducing length of stay. And if you do a procedure open, the patients tend to be longer in the hospital using resources than if you're able to do it minimally invasive. With that, we're able to reduce the total cost of care, even if there's some more upfront costs with the technology because of short length of stay. And also remember the way that some of the carriers, including Medicare, penalize you for readmissions. penalize you for wound infections. Things that we can do to reduce those complications are good for the patients and good also for the bottom line of the hospital. We want to make sure that if we are going to be moving to robotics, and this gets to the point of having adequate access so that people can be facile, we've got to have best of class. So in other words, our OR times, we understand earlier, will be longer than with laparoscopy or open, but we expect to see those coming down. And we really leverage some of our feedback information that we give to each of the clinicians to help them learn from the best of how people are doing it. And they themselves are improving. We're trying to get the rising tide truly to raise all the boats. Credentialing is a big issue, both initial credentialing as well as volumes. We can perhaps deal with that a little bit more in the question and answer. And we're doing a lot of very interesting work on human factors. The fact that you sit down, the fact that you have 3D, but how do we turn rooms over? And we're fortunate to have some human factors experts initially that trained in aviation and have brought some of that expertise, and that's something that Danny has been driving. So what did we do? One of the unique things that Intuitive has been able to offer us is this custom analytics that doesn't just look at robotics, it looks at our entire surgical service lines. But it is pretty amazing the amount of information that you can draw off of each of the individual platforms. How long is a surgeon at the console? How many instrument exchanges do you have? Intuitive is doing some fascinating work looking at actually the movement of the tips and seeing that as people get better and better, there's less and less wasted motion. So there's a huge amount of data that are available that we can use not only to understand and improve the financial aspects, but also to improve the performance of our surgeons. So whenever you're going to measure something, you need a baseline, and then you're going to set your goals. And anytime that you look at data, remember that, and also remember that you need to think about risk adjustment. What did we see when we initially pulled our data, not just on the robot, but on our overall service lines? And that is that we had an opportunity to address a good number of open procedures in some of those areas that I showed you. That even doing it open does provide healthy contribution margins, because you say, well, it's less expensive. But when we then start looking at the additional length of stay, especially at a time when the hospital is full and we can't get new patients in, or we have to house them in alternative care areas, it's really important to look at your contribution margins pretty much on a per day basis or on a per day per bed basis, because that's how you're going to overall figure out your bottom line. We want to look at outcomes, and we want to be very transparent in sharing outcomes with our clinicians, because if we're able to share those outcomes, especially showing them fellow clinicians that perhaps are doing it a little better than them, everybody can move. And we need to work on getting our robotic OR times down closer to what we see with either open or conventional laparoscopic surgery. The areas of greatest availability are the areas that we think we should be pushing. Certainly colectomies and elective colectomies especially. Many of our more senior surgeons are comfortable, they're very good at doing open colectomies, but it's a long incision. There are pain issues, there are infection issues, ventral hernia issues, and a colectomy isn't always such a straightforward thing to do laparoscopically, and even if you do it laparoscopically, many folks feel that they then need to make an incision to actually do the anastomosis, whereas with the robot we can do intracorporeal anastomoses far easier. GYN is another one, and especially our GYN oncology colleagues who want to be able to do staging. They want to be able to work in multiple quadrants, and again, being able to do this with minimally invasive techniques is good for the patients. So when we look at key performance indicators, now I want to point out from the get-go on this that not all of this is completely risk adjusted. But when we're looking at colon resections, these are elective colon resections. Now, some of the open ones could well be for recurrent cancers and other things that you have to do open. But when you look at the number of patients that have to go to an ICU after an elective colon resection, 17% of our patients ended up in the ICU. So this is not perforated diverticulitis or a gunshot wound. These are patients that should have been prepared and ready to go in. When we do this with minimally invasive techniques, the ICU admission rate is lower. The blood transfusion rate, pretty much across the board, has been good. We have a very active blood conservation practice here. Conversions to open, a little bit higher with laparoscopy. Again, I think reflecting the fact that a laparoscopic colectomy is a bit more difficult to do than an open. But even with the Da Vinci, about a little less than 1 in 20, 1 in 15 are converted to open. And surgical site infections, smaller incisions lead to smaller and lower rates of infection. And these surgical site infections, these are primarily superficial site infections. Obviously, anastomotic leaks and so on are separate. What are the financial things that drive? Well, honestly, it does take us a little bit longer to do these with the Da Vinci, although those times are coming down. When we look at the length of stay, the minimally invasive, whether it is robotic or open, the Da Vinci is about half a day less. Again, some of that may be patient selection. When you look at your contribution margin, but then look at the number of days that you've tied up a hospital bed on a per day basis, you're a little bit ahead with the Da Vinci. And part of that may also be that the groups that we're seeing that are coming, that are asking for robotic surgery, that are driving robotic surgery, at least for now, tend to have a higher commercial payer mix as opposed to the governmental payers. That may be shifting down the road, we don't know that. But the fact being that the shorter lengths of stay, even if you're on a case rate, is going to be very important. And you can see that our modalities, we really are a leader in minimally invasive surgery. About 2/3 of our colon resections are being done with minimally invasive techniques. These are the open procedures that we talked about. This is for the last 2 years, 2019 and 2020. Ventral hernia being our leading, followed by inguinal hernia and then colorectal. And that's about 81% when we also tie in GYN. Now, how do we get people to get better? Well, not surprisingly, and I'm a fan of Prairie Home Companion and Lake Wobegon, where, as you know, all the children are above average. Well, it's impossible for everybody to be above average. When you have a bell curve, you're going to have variation. So one of the things that we've been looking at is that we look at individual surgeons and we look at the costs, we look at the OR times, we look at how long it takes them to do a procedure and what their costs are, both when they are in the operating room utilizing materials, but more importantly, across the board, including how long are the patients in and what kind of readmission rates are we seeing. So over the last few years, we've developed this dashboard, and all of our surgeons, and what I'm showing you here is for a urologist. All of our surgeons every quarter receive a rolling 12-month report of the top 5 cases they've done, and we show them the cost of their implants, because especially for our orthopods, we may have some differences. We show them other things that are used in the operating room. We share their cards with them, which has been very enlightening. Many times they say, well, geez, you're charging me for something I haven't used in years. So again, if you don't show people their data, you're not able to really tighten things up. And if you see here on the bottom, we show them for their laparoscopic or their robotics, we show them the number of Da Vinci's that instruments they use and how many they use. So for example, if there are 34 cases and you use 35, in one case you may have opened up 2 harmonics. What that teaches us is if you see somebody who's opening up duplicative arms, is there a way perhaps to take and move it from one side to the other as opposed to open a second? In other words, you absolutely have to have 2 of the same instruments. And more importantly, besides your own cost, we show the costs of the lowest cost surgeons and what are the things that they use. So for example, the surgeon that I talked to you about, their greatest thing is to use the harmonic, whereas some of the more low-cost surgeons for cautery use monopolars. So again, not to say that there's one or the other is better or worse, but it does show some of the variation. And by sharing this, people have a chance to think about their own practice. The other thing that we'll then do is show you where you sit relative to everyone else. And we show who the best performing surgeons are. And we also give you the chance to see where you sit. And in this case, this is for robotic prostatectomy on the surgeon that we discussed. And you say, geez, they're number 4 in cost. Their costs are actually higher. But when you look at their length of stay index, you look at their average length of stay and their total direct costs, that is for the period of time that those patients are in the hospital, they're actually less costly than others. They're the number 1 performer. So when you show somebody only a single data point without relevant outcomes, you lose credibility. So we very much have committed ourselves, if we're going to compare folks to each other, we're going to also compare outcomes and give folks a chance to really look at how well they're doing and how they can improve. What else came from this? Well, we really recognized that this is a multidisciplinary process. So we developed work groups within our robotics steering committee to look at the clinical, the economic, the operational performance of our robotics. We've had surgeon level meetings, one-on-one, usually with a fellow surgeon that has robotics experience as opposed to somebody who is just talking off of the numbers. And then we, because of the ability to consolidate using the AMP program, getting 4 or 5 systems on one floor. And we're kind of unique because we actually have 5 different floors of operating rooms, each sort of specialty specific. We've made the commitment to bring a group together, and Alfonso is going to talk to you about really some tremendous successes with that, and allowing us to then do things with addressing block times and looking more at robotic blocks as opposed to individual surgeons' blocks. So the key takeaway, get the surgeons together, get them together early, get them together often, be willing to share the data with them. Let them help you interpret it. Recognize that a single point that is more expensive or less expensive may not represent the total quality or the total outcomes. And when you're doing that, and when we get everybody in the same room or on the same Zoom call for the last year, what you see is a much more unified voice. And you see people willing to trade things off, looking at different days that it may be better for them to operate. And we've been really, really successful with that. So with that, I'm going to turn it over to Danny Shohat. Danny, it's been really fun for us because he was one of our residents. We sent him away to a fellowship at Mount Sinai, and then he came back to us and has helped us really drive the growth of this program, as well as our minimally invasive fellowship, and very excitingly, the ability to begin to credential our general surgery residents. So Danny, the floor is yours.
Well, thank you, Harry, so much. That was an excellent introduction and overview, the 30,000 view of our program. And I really want to thank Becker's Healthcare for the opportunity to talk to you guys, and especially Intuitive for their past, current, and ongoing future support of our robotics program. So as you can see here, my training is, as Dr. Sachs mentioned, I did my general surgery residency here, and for better or for worse, during my training, robotics was not a big thing within our field. So I actually had no exposure to robotic surgery during those 5 years. And even when I went off to fellowship at the other Sinai in New York, I had a total of exposure of 1.5 cases. That half case was a case that was quickly converted from robotics to open. So my exposure was minimal during my training. However, after experiencing what the robot has to offer at one of our national conferences, when I test drove it, I knew right away that robotics was the future. So early on in my attending career, I went and got trained with the support of Intuitive. And I started doing a handful of easy cases, inguinal hernias and gallbladders. And unconventionally, I quickly jumped into doing complex cases, which is just part of my character. And for better or worse, it did result in a lot of struggles. So long operative times and a very steep learning curve. When I was doing these tougher bariatric foregut and complex abdominal wall cases, but some good did come from it. And the benefits was that although I had a very steep learning curve, it was a relatively faster learning curve and what I believe to be an efficient learning curve. Now, one of the advantages to robotics is the ergonomics, and there was an aha moment that I had early on in my robotics journey. So this was me in Switzerland with the Matterhorn behind me, and on my second day of snowboarding after a 10-year hiatus from being on the slopes, I had a pretty bad fall, and these are my injuries. So I was there for about a week, where a physician told me that I just had some bruised bones and to kind of toughen it out. And when I came back and I did a 4-hour case laparoscopically with my partner, I had a really tough time walking afterwards. So, of course, when I went to see the specialist and I started getting MRIs from foot up to my head, these are all the injuries that I had incurred. And you can see them all here. So for approximately 6 weeks, I was walking around with a boot and a swing on my shoulder. I didn't have the neck brace or the cane, but it was a struggle, and it was very scary for me because I thought that I was going to be out of commission for 6 weeks, especially early on in my career, where I was trying to kind of build my my referral pattern. This is me a week later doing the hardest and most complex surgery that I do, laparoscopic or robotically, called a median arcuate ligament release. And the reason why this operation is so tough and scary is that I'm literally operating on top of 5 different arteries, including the aorta and celiac trunk. So how was I able to do this? Well, after I got my ports in, I jumped off. I jumped onto the robot, took off my my boot, took off my my sling, and I did a 4-hour case without any issues or problems and no pain afterwards, all because of the robot and the ergonomics that it offers. Now, as far as investing in your own time, I do have some advice and some takeaways from my own experience. One thing that I wish I had done more is to utilize the ecosystem that Intuitive offers. So attend the courses, attend the case observations. The one thing that I did not do, and I do emphasize and recommend that encourage others not to do, is do not dabble. If you are committed and want to jump in and want to become a robotic surgeon, you have to get into it right away. So I was doing 1 to 2 days of cases per week. I did this for 2 months straight, and as I said, it was a steep, a stressful learning curve, but a very quick and efficient one. And as soon as I got 30 to 50 cases under my belt, that learning curve, most of it was over. And as your program is growing, be patient, and at the same time ask for what you want, such as block time or more robots, and show that you need it and the value that it will bring. Now, how was I able to team up with Cedars in order to grow a program and to have a shared vision? Well, you have to have a shared vision and goals, and you have to gain support from administration. Now, we are very fortunate to have someone like Dr. Sachs, who sees the value in robotics and did not require much convincing. But if you're in a program where that is necessary, the first thing I'll tell you is that there's power in numbers. So align with other surgeons, join your robotics committee. If you don't have a robotics committee, create one. Get others excited through education, expand your fleet of surgeons, and measure and communicate the value early on. So track your outcomes, calculate the contribution margins that Dr. Sachs demonstrated, and show the decreased length of stay. And with this, you and the institution can then align with shared goals. Now, what are some of those shared vision and goals? Well, everyone wants improved quality and outcomes. For Cedars, education and mentorship is a big part of our mission. Research and innovation, likewise. Value and efficiency is something that I think all institutions share in common, and everyone wants to grow their programs. Now, as far as collaboration goes, one of the best and easy ways to do this is through your robotics surgery steering committee. And like I said, if you don't have one, form one. So find the urologists or the gynecologists or the other surgeons out there who are interested in robotics and form a team. Now, this is a little bit of a description of our robotics committee that we have every month. First and foremost, the structure, it's a monthly meeting. And most importantly, the agenda is established with input from our own members. And we come together with shared purpose and goals. We have a multidisciplinary team of 25 surgeons from all different specialties, including cardiac, colorectal, general surgery, bariatrics, gynecology, thoracic, and urology. And we also have the advantage and benefit of having administration and OR operational leaders, as well as intuitive representatives and regional leaders attending this. Once again, forming a very multidisciplinary committee. Other ways to collaborate. So national conferences where they have their own robotics committees. And as I said, I did this to a certain degree, but I encourage everyone to do this as much as they can. Attend the intuitive conferences and the courses that they offer. Get involved with social media. There are many people out there going through the exact same growth, struggles, excitement in the journey with you. And it's always nice to be able to share that all together. And as I've said already, the robotics committee is a great way to create collaboration. As Dr. Sachs was able to show, our program grew rapidly. And you can see here that a big area of that growth was in general surgery. Thoracic surgery has also done the same with one of our leaders, Dr. Circassian, who was one of the first people, I believe, in the country, definitely in the West Coast, to adopt the ION technology. And his service line has become 100% robotic over the last year. And our current evolution. So we did see that one of the areas that we wanted to improve was GYN. So the first thing we did was to address their access issues. We train more staff so that there's the ability to do robotics in different areas of the hospital. And we've had the privilege of recruiting some big names in robotic gynecology, including Kenneth Kim and Murray Trong, who have been instrumental in growing their robotics programs, both from a clinical standpoint and from an educational standpoint. And some of the things that we're working on now, so standardization, we think is key. So we're trying to standardize our instrument trays to decrease cost, decrease waste, and decrease OR costs, as well as improving the efficiency of our OR turnover. So once you get past the teaching phase or learning phase of robotic surgery, I believe right now across the country there's a big push for efficiency. So with Tara Cohen and other human factors experts, along with myself, we took on the project of trying to improve our efficiency within the OR, and with a lot of help from OR administration, as well as the department. We were very instrumental in doing this through a very systematic human factors approach, where we were able to reduce our turnover from 72 minutes down to 45 minutes. The final piece I'll touch on is education and mentorship. And this has been a big area of my interest, and something that I've been very lucky to be part of. So other ways to grow your program is to get residents engaged and involved. And I saw that there was a lack of curriculum and a lack of residents to be as engaged as they can be when it does come to robotics. So the advantages of training residents robotically, well, I can tell you that training them laparoscopically is difficult. It's complex. There's a lot of difficulties with trying to show somebody how to do a certain part of the case, where you have to go onto the other side of the patient. However, teaching robotics was more seamless. It was more efficient, and it was safer. Cedars-Sinai was, again, dedicated to education, so they invested in dual consoles for us, as you can see here. And with that dual console, you're able to demonstrate what you want to do technically without having to change positions. You have the ability to telestrate, and the safety portion of it comes that you can instantaneously stop a resident from doing something that might be harmful to the patient by simply stepping on the camera pedal. Now, our residency curriculum is a 5-year curriculum that involves online modules, which now we have our incoming interns complete before they even start residency. They perform their bedside training in their first 2 years. We now have an advanced bedside training program that Dr. Trong and myself have put together. And simulation. Simulation is a big part of our training, which I'll touch upon in the next slide. Once they've done those, then they get onto the console, where they're actually serving as the surgeon. And the console training primarily takes place during their 2nd, 3rd, 4th, and 5th years. And finally, our curriculum involves evaluation from our faculty, who are heavily involved with the curriculum as well. So how do we increase resident practice? Well, with the help of our residency program director, who has been very supportive of robotic training, we address some of their time constraints. So they have protected time now to go to the simulation lab. And robotics has now been incorporated into our skills lab. Accessibility is important as far as the simulator goes. So we partnered up with Intuitive, and we have 2 different simulators in 2 completely different areas to provide as much access as possible, one in the operating room and one in our sim center. And the other thing that we've done is we've engaged our residents. So we've tried to make it fun for them. We've created competitions, we've distributed awards and recognition for those who are performing highest on the simulator exercises. One other thing that we did was that we held a faculty retreat. So we had all of our robotic surgery attendings attend this retreat where we disseminated the curriculum, but more importantly, tried to gain insight from some of the robotic attendings who have had their own tricks and pearls on teaching, and this is what came from it. So the first thing that I tried to emphasize to them was for them to emphasize teaching surgery. It's my job to teach the residents how to use the robot outside of the operating room, and it's their job to teach the residents how to do surgery with the robot. Some good things that came out of this discussion and this panel discussion that we had is to keep the residents engaged. So maintain dialogue with them. Even if they're not doing a part of the case, you can explain it to them while you're doing it. Don't allow them to bring their cell phones to the console. And give up, as tempting as it is to do those easier parts of the case yourself, give those parts up to the resident. And the paradigm or dogma of see one, do one, teach one is no longer applicable in robotic surgery and not necessary. So you can do a stepwise approach. Start with allowing them to have control of one arm. Then introduce the camera with the arm, and they can introduce additional arms as well, so they can ease into the surgery. Now, with our curriculum in place, we had the huge honor of graduating our first generation of residents, chief residents last year. As you can see, the 3 here, one of them going into transplant, hepatobiliary, one into surgeon, and one into breast. All 3 of these residents were superstars and were able to achieve a certificate of a competency so that when they want to start doing the robotic surgery, they don't have to go through that 1-year process of training and proctoring as I had to do. And with the combination of all the things that I've mentioned, so with this multidisciplinary team of surgeons, with the residency training and curriculum in place, with a very robust robotics steering committee committed to improving and enhancing each of our goals, with our commitment to excellence, to both quality, outcomes, education, research, innovation, and growth, we were honored to be entitled one of the Catalyst programs by Intuitive in the country. There are 7 Catalyst programs right now within the United States. We are the Catalyst program in the Western region of the US, and we have the privilege of providing academic mentorship to other programs and other academic institutes that are looking to replicate what we've been able to do over the last several years, as you can see here. So I'll leave you with this. What are the key points to growing a robotics program? First and foremost, invest in your own training. Attend the courses, go to the case observations, attend conferences, and get involved with committees nationally. Obtain a shared vision with your administration and with the hospital. There are common themes for all institutions. Everyone, surgeons and administration alike, want improved quality and outcomes. They want a value and efficiency, which is equally important, and programmatic growth. And something that's been very unique to us at Cedars is that we are very interested in research and innovation, which is something that we were able to share in common as well. Next, collaborate with others. So start with your own colleagues at your institution, attend national conferences. There are many out there who are going through the same struggles and excitement and journey that you are. Get on social media and join those committees, not just within your own institution, but national ones as well. And finally, we do have a focus on education and mentorship. This is a very important mission for Cedars, where we lead by example, and it has helped us to grow our own program by getting others engaged, including our trainees. And mentoring other programs through our Catalyst program has really allowed us to foster collaboration with people outside of our institution as well. Once again, I want to thank both Becker's and Intuitive for this wonderful event and opportunity. And I'm happy to turn over the floor and mic now to Alfonso Chicas, who has been instrumental and paramount in helping us to develop our robotics program and been a big part of this journey with us. Thank you so much.
Thank you, Danny, for that introduction, and thank you for presenting our program in such a professional and highlighting all the great work that we've done together along with Dr. Sachs. So my name is Alfonso Chicas. I'm the Executive Director of Perioperative Services at Cedars-Sinai Medical Center, and have the honor of presenting here today, talking about the growth of our program and establishing a culture of efficiency, having so many robotic platforms available and the multi-specialties that we perform here. It is very important for us to be as thoughtful and efficient with all of the resources that we have available to us here. And you heard a little bit about this from both Danny and Dr. Sachs here. And as you can see, as I described the number of units that we have, newer platform, standardized platforms for a variety of multiple services. So from my perspective, the on-the-ground workforce required to be able to handle everything from cardiac, thoracic, hepatobiliary, down to head and neck procedures really was a challenge for us. And as you can imagine, you know, we went through a learning curve ourselves in helping establish the culture of safety, working very closely and directly with our staff, our educators, and our surgeons. So what we feel was key for our operational success was, as you've heard, is really in that alignment between administration, the surgeons, and all of our leaders on the ground, with our nursing staff, with our SPD staff, really all the way from the top down, or I would say from the bottom up. The staff was very instrumental in ensuring our success when we had only 4 units and we had a very centralized team. It was a lot easier to get that buy-in as we gradually expanded and expected more and more of our staff really buy in and support our growing program, it was a little bit more challenging. So we really had to work to set that expectation up front and making sure that people understood that we were going to be a robotic center of excellence. We were going to be leading minimally invasive surgery in the West, in the LA County area. And in order to do that, you really need very strong hands-on support. And we're very fortunate to have someone in our robotic specialist role who has been doing this for quite some time and really is, I would say, one of a kind individual who this is his passion, and he really has jumped all in making this program very successful. An experienced nurse who has scrubbed the cases, who has been in the rooms, and who can talk with both the staff and the surgeons to ensure that we're traveling down the same path. The other key challenge that we faced that we were able to tackle, again, with the help of strong physician leadership support and really the buy-in from the Robotic Steering Committee, was in helping coordinate and cohort as much of our services within the same space. And I'll talk a little bit more about that here. And then last but not least, it's always important to recognize the staff and to celebrate successes, which we have been blessed to have many of in the last several years. So leadership and surgeon alignment, when we first started here, there really was some resistance to expanding robotic programs. Obviously, robots were expensive. Again, it required a lot of training, new supplies, new instrumentation. And so, we worked very closely hand in hand with Dr. Sachs and the Robotic Steering Committee. I was very impressed coming here roughly 3 years ago to see the engagement and the interest within robotics at Cedars-Sinai Medical Center. And that, to me, was an opportunity to listen and to engage with them and to figure out where we wanted to go collectively as a program. And one of the decisions that we made early on, because Intuitive really wasn't invited, they didn't have a seat at the table, and having my background and experience in developing new programs, it didn't make sense to me to leave out our key partner and who we knew had available resources and could really contribute to our program growth. And so we quickly changed that and again added additional key members to our robotic steering committee, including surgery scheduling, including our business director. Those were other key folks that we added to our list. As you might imagine, again, growing our program, growing the number of units available posed a challenge for our schedulers and for the offices, and being able to get not just robotic time, but robotic time mixed in with some of the other cases that our surgeons were performing. And so the revamp of our block schedule was something that was no easy task, but really was the work of our robotic chair, working with our surgery schedulers, our data analyst, and evaluating our block schedule. Intuitive provided very helpful information and data as well. And finally, after I would say close to a year, we were able to move all the pieces around, really open up dedicated robotic time, both for individual services, but also as open robotic time to improve access. So we had eliminated the concerns or the issues that our surgeons had brought to us in terms of not having enough robots, as you heard Dr. Sachs speak about the introduction of the AMP program, which very quickly added 3 additional units to our fleet. But with that, again, where are you going to put them? How are we going to allow surgeons to schedule into those units? And so the revamp of the surgery block schedule was very important to do that. And again, even though it took us a year to do, it was because we were constantly refining our efforts to help improve access to the elective schedule. So And then, you know, also, again, a real big challenge for us was in how do we staff these ORs? And as many of you know, a robotic case, at least in the beginning, is not like any other case. It does take time. It does require additional support and either bringing the equipment in or setting up the equipment. We're very fortunate here at Cedars-Sinai Medical Center where we have very specialized roles, and that could be both a blessing and a curse. And people expected to have, you know, some level of support when starting to do these robotic cases. And so we had to go out and very quickly train more folks to be able to help out the circulators and the techs in the room. And we're fortunate to have that in some of our what we call logistical technicians who help us in simply getting things ready and prepared for each case. I'm going to talk a little bit more about the block schedule because I know that this is often a hot topic. And one of the things that we were able to do as we were expanding our facilities and adding additional rooms, that was a golden opportunity for us to move things around and to place people where it made most sense to do so. And I'll show you an example of this momentarily. But even though we were doing most of our robotic cases in one particular OR suite, we weren't doing them all there. And so there was an opportunity to consolidate in order to maximize the benefits of having a consistent team, having the supplies and the instrument trays in one space. Again, limiting variability, limiting movement of either personnel or equipment. And so we were able to cohort most of our cases within one space. Cardiac is its own separate suite here, and so we kept a dedicated room there for them. And in addition, we carved out another unit for hepatobiliary where we do some of our transplant cases. And then last but not least, having the luxury of a brand new outpatient-based facility, we were able to place one of our AMP program robots over in that OR suite. So then we could cohort, you know, some of those outpatient cases, the inguinal hernias and some of those lap choles that could go home the same day, not tying up valuable space in our main operating room suite where we do some of our more complex inpatient type cases. So that was a real victory for us. And again, we did this with full transparency. So looking at the data, analyzing who was doing these cases, where they were being done, we were able to highlight and to see what services really needed time. And honestly, what the data showed was that we had plenty of robots available. We had plenty of time available. We just needed to align the schedulers in the doctor's offices to work within the allocated times that we had, which again is no easy task. And I would say that we still continue to face some challenges in being able to truly maximize a full day, get a full utilization of an entire OR suite. And that is our intent by having all the robots in one particular OR. So again, I suspect that as you grow your program, you will need to consider where and how you can consolidate your systems in order to maximize the benefits from the staffing and the supply and instrument piece. You know, talking about staffing, again, we were able to expand because we're very fortunate in where we have generally once or twice a year a new grad program. And so we set the expectation up front for anybody coming in, not just through our OR residency program, but also as experienced nurses that we would hire, that, you know, we do robotic training as part of our initial onboarding. And so as I mentioned about the support that was needed in the rooms, we started by looking at some of our expert clinicians, some of our folks who had been here who actually had expressed an interest in being in robotics, but for whatever reason were kind of left out of the training or being part of that. And so we tapped into those folks up front, cross-trained them, had them be some of our robotic leads, and help mentor some of the new staff. So the other reason why that was important is because then as we expanded our service line offerings, then we were able to place one of these nurses, match them up with one of the surgeons to help work on the preference card issue, help work on some of the tray issues, and again, gradually improve our overall efficiency. And so talking about the teams, you know, again, we couldn't only have one or even two teams for each service. We really needed to have a strong, large group of folks that could step in and could handle these cases, not just during the morning hours of the day, but obviously into the mid shift and even into the evening shift. You know, that was always a big fear of our surgeons, is that 3 o'clock, you know, witching hour, where all of a sudden all the experts leave and you get, you know, team B. That just couldn't be the case here. And so that was extremely important and valuable that our robotic specialists work with not just the morning shift folks, but also the afternoon and the evening folks as well. And as I mentioned, you know, it was really important for us to celebrate these successes, and you'll see some of that here as we move forward. We're very fortunate here at Cedars-Sinai Medical Center to have a very advanced simulation training center. And so, again, our robotic specialist was able to work hand in hand. He came in on Saturdays, stayed after hours to help work together with our teams, not just in the operating room, but I would say in sterile processing as well. Intuitive was a very key component of that. The other key point here is that we needed to document this. So again, it's not uncommon to hear someone who may be hesitant or reluctant to go in a room saying that they haven't been trained, they're not familiar with the robot. And so we started this last year and ensuring that this is part of our annual competency. And so we have a checklist that our folks go through to document the training that they receive, and any of the any of the training that they receive is documented and placed in their file. So the benefit of training the support staff, training the nurses, having them be part of a service line team, is that they help us with updating the preference cards, and actually working with our human factors scientists. Even the preference cards we looked at to make sure that they were easy to read, easy to understand, and that whoever was looking at them was focused on the things that they needed to do. So, you know, a complaint of our surgeons is that, you know, my preference card is there, it's updated, no one's looking at it. We wanted to make it easier for them to look at the preference card and to really highlight the key points of that. So we shifted that around and put in specific notes for the techs and for the nurses and then other key components. And now I understand that within OpTime, you can actually put in pictures or photos of setups and tools and equipment and things like that. So we'll be doing that here going forward. So logistics, again, this is just, you know, how you put all the pieces together, and our human factors team was very instrumental in helping us and looking at some of our custom pack builds, our trays, as we talked about, along with standardizing some positioning equipment and looking at some of our more complex cases that are generally with more than one team coming together. So our instrument sheets, again, a lot of work here to clean up what had just built up over time. Again, not uncommon, I suspect, at your facility, but with the help of many folks, specifically the folks in our data department, we were able to go back and look at how often a particular tray or how a particular instrument was being utilized. Our human factors team actually spent many hours and many days in the operating room, helping look at what was actually being used and what was actually being done routinely. And so they were extremely helpful in helping us analyze our preference cards and helping us trim our trays. So this is an example of what our robotic tray looks like. I'm not particularly sure what service this is for, but it's kind of our standard robotic tray. And as you can see, it's very limited. It has the basics that you need. And the rest of the items are placed in peel pack. And this was not done in silos. So we went around and spoke with each of the key service line surgeons and showed them the information, showed them that despite you having this on your preference card, it really wasn't utilized very often. And so we got a lot of buy-in and support for this program. And again, it really has helped in streamlining our overall operations. So, you know, again, as we wind down here, I just want to share with you, you know, some of our successes that we've been able to achieve. And again, can't give enough credit to our robotic specialist. He's been very key in a lot of this work, working again with our educators, with our sterile processing department. He has an excellent relationship with the surgeons, and I would say with Intuitive as well. And because of that, we've been able to accomplish many great things, including some of the work in reducing our turnaround time, as you heard, improving our instrument tray, and then also improving our overall program growth and alignment. So I'll leave you with, again, the keys to creating a culture of efficiency within your program, within your operating rooms. I think consistently you heard from Dr. Sachs and Dr. Shoehead, you have to have all three components together. You have to have, I think, the support of your vendors, Intuitive here, nursing and administration, along with physician leadership support. Clearly the staff buy-in is instrumental, and you have to set that expectation up front. You have to get people excited about being a leading minimally invasive center, a leading robotics institute. The hands-on training is very critical and important. People are afraid of the robots. They're afraid they're going to break it. They're afraid, you know, they can't move it. And so it's very important. And again, we're very fortunate and blessed to have that simulation center where we can have a robot there to work with and to train, again, not just the nursing staff in the rooms, but also some of the other folks that participate in the procedures. Again, getting the rooms together, aligning the cases where it makes sense, trying to organize the trays and the supplies, cohorting all the talent and the skills is very important. And then last but not least, celebrating those successes, recognizing and rewarding the folks who help you achieve success. And with that, I'll be happy to turn it back over to our program.
Thank you, Dr. Sachs, Dr. Shohat, and Alfonso. We'd now like to open up the floor for Q&A. So please submit any questions you have through the Q&A box you see on your attendee dashboard. And if we're not able to get to your question in the time we have today, we will be sure to follow up with you after the program to get those addressed. We've already had several questions come through, so we're going to go ahead and get started with the first one. And this person asks, it can be hard to change the culture around robotics at a large academic institution. How were you able to align your team to achieve your individual goals? And I'd like to hear from all of our presenters today on this question. Dr. Sachs, can we begin with you?
Sure. I think, you know, you look at two things. One is what's best for the patient, and also what are the demands that we're seeing in the marketplace, both from patients and from clinicians, because I think we want to draw in both. And so from our point of view, having a really strong robotics program was something that was consistent with the level of excellence that we have at Cedars. as well as to maintain and to draw in the best and the brightest of our clinicians, many of whom went the robotic technology. So it was a pretty straightforward decision.
Thank you so much, Dr. Sachs. And Dr. Shohat or Alfonso, would you like to chime in on this question as well?
Yeah, sure. I think first and foremost, we're lucky to have a minimally invasive surgery culture already established here at Cedars historically. And even if you don't, there's two ways about it, and I think we did both. One is a top-down approach, so you have to get your administrative support. You can also do a bottoms-up support. So the residents, getting the trainees involved, engaging them, educating others around you, and demonstrating the value. And I think one thing in general, as far as culture goes, is empowering others and getting them excited about of new technology and new programs.
And I'll just add that the consistency in the message coming from both us as nursing leaders and administrators, aligning with what the surgeons were saying, and seeing that this was the direction that we needed to take as a world-class institution. We could not fall behind in this technology. And so getting people excited about, being innovative, really leading patient care, improving the outcomes, and making as many offerings available to our patients. I think that was very important. And as you heard earlier, and kind of having that shared vision, that truly helped set things in motion to transform the culture from where it was 3 years ago when I got here, or 10 years ago when Harry got here. But really in the last, I would say 3 to 5 years, this was the direction that we were headed, and I think we were all marching to the same beat and saying the same message.
Thank you all. Thank you all for your input there and your insight. We've had a few more questions come through, so we're going to go ahead and keep moving through these. And the next question that came through is for you, Dr. Sachs. And this person says, you clearly made a major investment in this strategy, but what were your ultimate reasons to enter an accelerated robotic MIS strategy with Intuitive acquiring all those systems? And has it helped with your surgeon access to the technology?
Right, and that's a really, I think, key aspect of our success. Early on, robotics was a major upfront capital investment, north of $2 million. And at the same time, our surgeons wanted it more, they wanted to be able to use it. The learning curve, because it took surgeons longer early on, we couldn't get people on as much. And so the question was, do you spend a lot of capital in trying to buy more systems that may not be utilized or may not be utilized efficiently? And so we actually were able to come into this AMP program, which is essentially a per click. And we have a hybrid mix. So we have some platforms that we own. We have some platforms that we lease on a per click basis. And we also were able to standardize, as I mentioned. So we're an all XI system with the SP and the ION. What we then do with the scheduling is if we have, say, a case, a bunch of shorter cases, hernias, gallbladders, that are going to be rapid turnover, we'll use the owned systems for those. And then if we have maybe 1 or 2 longer cases a day, we'll do the per click. Or if we have a surgeon that's learning and we know it's going to take them longer, we'll use one of the AMP systems for that, recognizing that that really helps stabilize what our fixed expenses are. It's been a really wonderful experience for us. And the fact also that we were able to upgrade to coming across the board with XIs helped us with standardization.
Thank you. And Dr. Shohat, would you like to weigh in on the access piece about, has investing in these systems helped with surgeon access to the technology?
Yeah, absolutely. Access, I think, is an issue at many institutions. We were fortunate that the administration listened to our voices and responded appropriately. And I think that they see, we talk about the future being robotics. I think the present is robotics. I think the future is a robot in every room. Uh, Cedars has always been a hospital that's been invested in being at the cutting edge of technology and innovation. And this allowed us to continue that trend and to be at the front of that revolution. And when you see value in patient outcomes and satisfaction, it's easy for the administration to support you, and it clearly has been seen that way.
Yeah, and I wanted to add one thing as Danny was talking about strategy and access, and that's that we also need to look at the role of robotics outside of the four walls of the hospital, because as there are going to be more financial incentives as well as patient demands to go to ASCs, to go to short stay surgery centers, and to have robotic technology along with other high quality minimally invasive technology available, I think is going to become a competitive advantage as well going down the road.
Absolutely. Thank you both so much. And we're going to go ahead and move on to our next question now. And this person is asking, has COVID-19 affected how you look at throughput, and how is robotics affecting that strategy at your hospital? And then the second part is, how has the length of stay associated with robotics helped alleviate capacity constraints? So Dr. Sachs, I'll begin with you, and then we'll open it up to our other speakers as well.
Yeah, I'm just going to turn it over quickly to Alfonso because he's really been the one that drove this one. We've had to do two significant shutdowns, one about a year ago in March and one this past December. What we committed to on the second time around was to really maintain access for cancer. And so early on, we were deferring prostate cancers. We were able to do those now in our latest, when we had to pull back, get those patients the care they need, and we developed an overnight stay unit. So the patients never went into the main hospital. That also gave us the ability to some ways cohort into a relative COVID safe or COVID clean zone. So it's helped us, but robotics in and of itself, the types of cases that you do, especially the cancer cases, if you continue to do those and do those with a relatively short length of stay, that's great. But I can't say that robotics was, central to our ability to respond. It was one of many tools that we responded to, and I think Alfonso can expand on that far more.
Well, I would say in terms of robotics, I think the SP will definitely be a game changer in terms of robotic prostatectomies and helping decrease the length of stay and actually being able to take advantage of a unit that we've created, this outpatient surgical unit, and where we send patients directly to this unit, give them focused nursing attention to safely discharge them, maybe longer than what they would have in a normal PACU stay, and potentially even a one-night stay, and discharging them directly from there. So COVID did impact us tremendously, as I'm sure it impacted most of you, but we did find some silver linings, and we're able to think and do things a little bit differently to help ensure that we could remain open and available to the patients that needed our services. And our outpatient stay unit was one of those ideas that was able to come to fruition, I would say, a lot sooner because of COVID.
Thank you so much. And our next question that came through was just about kind of how else has COVID impacted your system, and has it accelerated your outpatient strategies? Dr. Shohad, would you like to weigh in on that, or Alfonso, anything else to add?
I can quickly just tell you that we did see changes in patterns in terms of scheduling. So prior to the pandemic, we really struggled a lot with patients that would be scheduled as procedure patients needing an overnight stay. And I think in part because of what patients were asking for and not wanting to be cohorted in a COVID area, we were able to separate those patients, separate them by doing many of these procedures in our outpatient space. And again, because I think the patient ask was there, we saw changes in not just the scheduling, but actually the performance. And again, because we were able to keep patients in our OSU and they were able to go home either the same day or the next day, we saw a decreasing number of what we call AM admits or same day admits. Many of the patients were truly outpatient, were able to go home in less than 24 hours.
That's
I
great.
think just to add on to that, with specific case examples, Dr. Sachs demonstrated that shorter length of stay in colorectal cases. So rather than having a 4 or 5 day stay with open procedure, you're looking at sometimes a 1 or 2 day stay. And even cases that typically are outpatient, like abdominal wall hernia repairs, particularly the complex ones where they might be in the hospital for 2 or 3 days because of pain control, we're seeing these going home the same day now when you're doing these robotically. So.
And that does remind me, I think we do need to give credit to our anesthesia colleagues too, because we did see changes in their anesthetic plans, doing a lot more regional and really focusing a lot of ERAS protocols as well during this time. So kudos to them for adapting and helping us achieve these goals.
Thank you so much. And the next question is for you, Dr. Shohat, and this person says, you clearly perform several robotic procedures each month. How did you work with administration to get increased access to robotic technology? And I know you touched on this in the presentation some, but would love to hear from you on this question.
Sure. This was as it is at all institutions, this was a big centerpiece at our robotics committee for quite some time. And, along with leadership, the process that we went through, we started with surveying the surgeons to see how many cases they currently perform and how many they think that they would perform if they had more access to the robot. And based on data that we had from that, we took this to administration and with Dr. Sachs' support and with support from our COO, they listened to us, and that's kind of how our AMP program evolved. The other things that we've done to try to improve access is by being able to do more cases. So one of the things that we've worked on is to improve efficiency, which was a big part of Alfonso's talk. So we tried to improve OR turnover, maybe one day with the potential to be able to add an extra case or two. And I think recently dedicating almost an entire floor to robotics also improves efficiency, throughput, and I think the combination of all that has really helped with access.
Thank you so much. And we had another question come through, and this one is for you, Alfonso. And this person, they said Cedars experienced massive growth with their Da Vinci robotic fleet in a relatively short amount of time. So are there any operational considerations that are watch outs, especially for those who are considering acquiring more than one Da Vinci system at a time?
Yes, absolutely. Again, the staff is key in making sure that staff are trained properly. Making sure that you have enough properly trained staff is really important. So you don't want to put patients at risk by having folks that are anxious or scared of doing these types of procedures. And with the rapid growth within our program, that's something that we tackled up front, as I mentioned, and just setting the expectation that anybody that comes to work for us here will be robotically trained, even to do the core cases. The other operational speed bump to look out for is in your sterile processing. So as those of you know, you need specialized handling, you need specialized processors or equipment down there. And so making sure that you have all that set up and ready to go, and those folks in sterile processing also familiar with the cleaning and the handling of these trays is something to be on the lookout for a rapidly expanding and growing program.
Yeah, and the one thing I would also add when you're talking about adding additional systems is take that opportunity to step back and see how much you can standardize. So again, an X is slightly different from an XI, certainly much different from an S. The SP is off on its own. You want to try to minimize the number of mixing and matching so that your inventory becomes more stabilized, more standardized, as well as the training and for each of your of the people that are supporting you. So it's a good time to think about standardization, not just in robotics technology, but if you're upgrading your MIS systems, if you're looking at the staplers you use, take those opportunities to look at trying to reduce the variation between vendors and so on.
Great point. Thank you so much, Dr. Sachs and Alfonso. And it looks like we have time for one more question, and we've had one more that came through for you, Alfonso. So you mentioned revamping your robotic block schedule, but how did you manage surgeon requests with robot availability?
Yeah, that's a good question, and one that I'm not quite sure we have fully solved yet. But I think, again, the key here is that, as you heard Dr. Sachs, we have 25 surgeons as part of our robotic steering committee. So really, all of them hear and see the information that is requested or provided. So there's a lot of transparency in knowing the challenges that we face, where there's only X number of rooms and robots available, and they see the challenge in having those limits in place. And what the group decides is ultimately what gets done. And so giving them a voice, not necessarily a choice, but having them share those concerns and having the group hear those concerns, again, I feel like we make better decisions as a whole. And so we can't give everybody their own individual block time. That just is not possible. But if they understand what we're trying to do to help improve access to the robots, help improve access to the elective schedule, they seem to kind of back off a little bit and help work within the system that is in place. So it will continue to be a challenge. And again, we want to have more of open robotic time available for those that truly do need it. What we ask is for some flexibility and giving us some options instead of one specific, everybody wants Tuesday, 7:30 in the mornings. Well, let's look at Wednesday, let's look at Thursday, let's look at some other options. If you give us some flexibility, we feel like we have plenty of capacity to be able to accommodate it, but we just need everybody to be flexible and adaptable. And ultimately, our goals are the same. We want to take care of your patients at Cedars-Sinai Medical Center, and we want to find a way to be able to do that. And we feel confident that we do that more times than not. So.
The flexibility is key there. Thank you so much. That is all the time that we have for today, but I want to thank Dr. Sachs, Dr. Shohat, and Alfonso for that excellent presentation, and a big thank you to Intuitive for sponsoring today's webinar. As a reminder, if we did not address your question today, we will be sure to follow up with you directly after today's webinar concludes. And for more information on today's content, please check out the additional resources on your webinar console, and don't forget to fill out the webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon and a great rest of your day.